Hello and welcome to this week's ECG of the week. Take a minute now to pause the video and familiarize yourself with the clinical vignette. Now let's take a look at his ECG. So we're going to use the 6-step method that we outlined in our ECG Basics tutorial, and you can find this on YouTube as well as our Facebook page. So first we're going to take a look at the rate. So let's zoom in here, and we're going to use the 300 method. So we'll take the R, the peaks here, and we're going to count the big boxes between them. So 1, 2, 3, 4, a little bit over 5. So 300 divided by 5 equals 60. So we're going to say the rate is around 60 beats per minute. Next, we're going to look at the rhythm. So what we like to do is take a note card or a piece of paper, and we'll draw out where the R's are, and we'll move this across the strip, and we see that they pretty much line up all the way across. So this is a regular rhythm. Next, we're going to take a look at the P waves. So we can see here that there is a P wave here, a P wave here, and these all occur before the Qrs complexes. So the P waves are present. Next, we're going to take a look at the Qrs complex, and we want this to be narrow. So let's find a good Qrs complex here. So this is maybe 1.5 small boxes. So this is less than 120 milliseconds. This would actually be closer to 0.04 is each small box, so that'd be 0.08 seconds or 80 milliseconds. So this is narrow. The Qrs complex is normal, and we can see that down here as well. This is about 1, 2. However, we do see an abnormality here that we'll come back to in a minute. And then the PR interval, we'll look at that next. So what we do is we find a nice P wave, and we have that here. So we'll go from the start of the P wave to the start of the Qrs complex, and this is 1, 2, 3, about 4 small boxes. So this would be, we're looking for a normal PR interval to be between 3 to 5 small boxes. So 4 is within that range, and that is less than 200 milliseconds. So this would be normal. We can see this in other leads as well. From here to here, it's about 1, 2, 3, 4. So this would be equal to 160 milliseconds. And finally, we're going to take a look back down here at the abnormality I pointed out earlier, and that is in the ST segment. So you may have seen already that there is ST segment elevation. We have this isoelectric line here, and you can see after the Qrs complex there is elevation at the J point, and that is consistent with ST elevation. So we actually see this is in lead 2. We'll zoom out and look and see where else we can find elevation. So we see ST elevation here as well. If you look at the J point, there's ST elevation here as well as here. And then if we go down to AVF, we can also see the isoelectric line is here, and there is elevation as well. So the next slide, we have our findings. The rate was 60 beats per minute. The rhythm is regular. P waves are present. The Qrs complex is narrow, so less than 120 milliseconds. The PR interval is normal, less than 200 milliseconds or 3 to 5 small boxes, less than 5 small boxes. The ST segment, we found that there was elevation in leads 2, 3, and AVF. So this would be an ST elevation myocardial infarction. and 2, 3 in AVF, this would actually be sorry, Eddie, go back to the beginning of this slide. 3, 2, 1. So now just looking at our ECG findings, we have the rate is 60 beats per minute. The rhythm is regular. The P wave is present. The QRS is narrow and normal. This is less than 3 small boxes, which correlates with 120 milliseconds. The PR interval is normal, so less than 200 milliseconds. The ST segment, we found elevation in 2, 3, and AVF. So our interpretation would be ST elevation, myocardial infarction, and this is actually an inferior STEMI, and we'll tell you how to localize this later in the slides. So the pathophysiology, the classical pathophysiology of a myocardial infarction is ischemic cardiac tissue death that usually occurs due to an acute thrombus. So when an atherosclerotic plaque bursts, its contents are thrombogenic, and this will promote clotting that can travel to the coronary arteries. The ST elevation on the ECG represents transmural ischemia, and this is different than presentations where the ischemia does not go all the way through the myocardial wall. That will present more as an end STEMI, although there may still be ischemia present in the heart. So classical presentations of a STEMI includes retrosternal chest pain, and this may radiate to the left jaw or arm, dyspnea, so trouble breathing, diaphoresis, sweating, as well as nausea. Diabetic patients, elderly patients, and female patients may all present atypically, so take extra care when working up these types of patients. Some of the complications of STEMI, including death, are a direct result of the degree of necrosis, which is tissue death. And there's actually a helpful way to remember some other complications of STEMIs and myocardial infarctions. And this is Darth Vader. So for all you Star Wars fans out there, this may be easy and help you remember some of the complications. D stands for death. A is arrhythmia, R is rupture, T is tamponade, H is heart failure, V is valve disease, A is aneurysm of the ventricle, D is Dressler syndrome, E is embolism, and R is recurrence of myocardial infarction. So here we have some rare etiologies, and I want to stress that these are rare, but it's also something you might want to look out for. So defects such as premature atrophy of the duct of Cuvier may lead to lack of blood supply to the heart. So we can see on the left here, we have a CT thorax, and you may see cardiac lesions with increased attenuation arising at the apex. So we have this marked out here by these little arrows, and this would lead to obstruction of the coronary arteries. Some other congenital defects that can result in myocardial infarction are any coronary artery anomalies. So an Al Kappa, which is an anomalous origin of the left coronary artery from the pulmonary artery, R Kappa, which is anomalous origin of the right coronary artery from the pulmonary artery, any ectopic origin of the coronary arteries from the aortic sinus, or absence completely of a coronary artery can lead to myocardial infarction. So some interpretation tips to help you localize where exactly the myocardial infarction is happening. If you look down here, we have leads 1, AVL, V5, and V6. These correlate with lateral STEMIs. 2, 3, and AVF, which is what we saw in our patient's ECG tracing. This would correspond to an inferior STEMI. V1 and V2 are septal, and V3 and V4 are anterior, so this is the anterior septal region. And we can actually see this transposed onto a real ECG, so this is kind of a helpful way to just learn where to localize these myocardial infarctions. So lateral, you'd look here at the top, as well as V5 and V6. Inferior is this kind of L shape, 2, 3, and AVF. And then anterior and septal, we have the two septal leads, V1 and V2, and then V3 and V4 are anterior. Some more interpretation tips. Some things like amplitude of the ST elevation are very important to consider. So to diagnose STEMI, we do need 1 millimeter of ST elevation in 2 contiguous leads. So 2 leads, one after the other. However, there are a couple exceptions to this. An anterior STEMI requires 2 millimeters of ST elevation in V2 and V3 in men who are older than 40 years old. And this is according to the American College of Cardiology and the American Heart Association's definition. And a total of 2.5 millimeters is required for men who are younger than 40 years old, and only 1.5 millimeters is required for women. The other exception is the posterior STEMI. So we frequently see ST depression actually in V1 to V3 instead of elevation because the vectors are completely reversed. So if we zoom in here to this posterior STEMI, we can see that there's actually depression of the ST segment instead of elevation. However, if we were to put on leads V7 to V9, which go around the back, we would see ST elevation. So, since these posterior changes actually occur from coronary thrombus and require urgent treatment, it is still classified as a STEMI, even though we see that this is going down. So on this slide, we see an example of hyperacute anteroseptal STEMI. Hyperacute T waves are broad-based, symmetrical, peaked, and usually with an increased amplitude. So if we zoom in here, we can see that we have ST elevation that is maximal here in the anteroseptal leads, V1, 2, 3, and 4. And we can see the hyperacute T waves we were talking about here in V2, V3, and V4. So very high amplitude. We have a peak up at the top and a broad base. And you can see here a departure from the isoelectric line that is indicative of a STEMI. If we zoom back out and look at a couple other leads, we can see some more subtle ST elevation. So if we go up to lead 1, we draw a line here across the isoelectric line, there is a little bit of ST elevation here. If we look at AVL, we can see that there's a little ST elevation here as well as back over here in V5. The reciprocal of these can be found in leads 3. We can see some ST depression. So if we zoom in here, draw a line across, we can see there is a little ST depression in lead 3. So these features overall would indicate a hyperacute anteroseptal STEMI. On the next slide here, we can see extensive anterolateral STEMI. So we have ST elevation in leads V2 to V6, as well as 1 and AVL. So let's zoom in here. So V2, 3, 4, 5, and 6. We can see we have ST elevation here, as well as in these leads. And we'll zoom in over here on 1. We can see elevation at the J point here, as well as down at AVF. This is depression here, but that would be flipped. So this is indicative of an extensive anterolateral STEMI. So just some takeaways. STEMI is a type of acute coronary syndrome that requires emergency reperfusion therapy. STEMIs can be quickly spotted and must be acted upon promptly. Some evidence of a STEMI will be ST segment elevation at the J point in 2 contiguous leads. CK&B and troponin, which are cardiac biomarkers, will also exceed the upper level of normal, and this is according to each individual hospital's laboratory parameters, and with a clinical presentation that is consistent or suggestive of ischemia. So this would be chest pain, diaphoresis, sweating, things that we talked about earlier. ST depression in leads opposite of the infarction can also strengthen suspicion for an MI, but we'd like to stress that they are not necessary to identify an MI. And just some points of caution: if ST elevation is present in all of the leads, consider pericarditis. However, no one will penalize you for working up the patient until proven otherwise. And beware of imposters. Some things such as pericarditis, benign early repolarization, left bundle branch block, LV aneurysm, and Brugada syndrome can all appear as STEMI. So make sure to take the time and go through the 6 steps. Oh God, I was so close. All right, start over on this slide. Thanks, Eddie. 3, 2, 1. So just some takeaways for STEMI. STEMI is a type of acute coronary syndrome that requires emergency reperfusion therapy. They can be quickly spotted and must be acted upon promptly. Evidence of a STEMI will include ST elevation at the J point in 2 contiguous leads. This is very important. You can also see CKMB and troponin exceeding the upper level of normal, as well as clinical presentation that is suggestive of ischemia. These things could include chest pain, diaphoresis, dyspnea, as well as a few other presentations. ST depression in leads opposite of the infarction also strengthens suspicion for an MI, but they are not necessary to identify an MI. And just some points of caution: if ST elevation is present in all of the leads, consider pericarditis as a possible diagnosis. However, no one will penalize you for working up the patient until this is proven otherwise. And beware of STEMI imposters. There are a few other things that can look like STEMI on an ECG tracing, such as pericarditis, benign early repolarization, left bundle branch block, LV aneurysm, and Brugada syndrome. Thanks for tuning in. Make sure to check out next week's video. Thanks.